Hello, my name is Matthew McCurdy, and I'm a third-year internal medicine resident with the University of Kentucky College of Medicine Bowling Green campus. I'd just like to talk about our quality improvement project that we did this year based on the sliding scale insulin regimen that we have and glycemic control of our type 2 diabetics. The idea behind the project came that when we saw that a lot of our practitioners were still using a sliding scale insulin regimen as a primary method of managing hyperglycemia in the hospital. We know this to be inferior based on previous randomized controlled trials such as the Rabbit2 trial, which showed that a basal bolus strategy is superior to that of a sliding scale insulin regimen alone, which is adopted by the ADA as an appropriate therapy. Now, when we talked to these practitioners and asked why they were still doing this, we found that hypoglycemia concern was the major issue in limiting, but also the fact that these practitioners were concerned that maybe our healthcare team members weren't administering the therapy the way it was prescribed. The way we checked this was we took a retrospective group of about 71 patients with a prospective group of about 98 patients, both treated with sliding scale insulin with only the prospective arm being appropriately optimized. The way we optimized this was making sure that our patients did not receive a dietary tray prior to their blood sugar being checked and making sure that they were getting their sliding scale insulin before they were eating, meaning it was a proactive versus reactive strategy, as well as making sure our nurses weren't inappropriately holding their sliding scale insulin for any reason. Our primary outcomes we were looking at was the adequate glycemic control, or the average adequate glycemic control for these patients based on ADA guidelines, which was a blood sugar between 70 to 140 milligrams per deciliter, as well as our individual blood glucose measures being adequate by that criteria, with our secondary outcome looking at the average overall length of stay. In the end, what we found was that 34 out of 98 patients in the prospective arm of the trial had average glycemic control that was considered adequate by those ADA guidelines versus only 14 out of 71 patients in the retrospective arm, which was clinically significant based on the p-value at 0.05. With a number needed to treat of about 7 patients with our intervention. We also found that the absolute risk reduction for these patients having inadequate glycemic control, either high or low, was about 14.9%. So we thought that was pretty good. Also, our individual blood glucose measurements, which we had about 5,974 individual measurements. Out of our prospective arm, 925 out of our 2,484 measurements were adequate within that glycemic range of 70 to 140 versus only 143 out of 3,490 of our retrospective group, which was also clinically significant in its improvement of 0.001 with an absolute risk reduction of about 13%. That means for every 8 measurements we were able to correct that to an adequate glycemic range. For our secondary outcome of total length of stay, we did not find it to be clinically significant. In our retrospective group, the average length of stay was 7 days versus our prospective arm, which was 5.7 days, so a little over a hospital day there, but the p-value was only 0.13. So in summary, despite our interventions, sliding scale insulin was not superior to a basal bolus strategy, which was known from previous history, and this was despite our optimization, and about 38% of our patients were only able to obtain adequate glycemic control based on those guidelines, with about 63% still remaining outside of that range. Also, our individual measurements, about 75% of the time fell outside of the adequate glycemic control range despite our optimization. That also would support that a basal bolus strategy was superior to a sliding scale insulin strategy alone. I really appreciate your time, and I know 3 minutes is very short, but if you have any questions, please feel free to reach out and contact me. Thank you.